So I'm just going to talk briefly through phase 1, which is probably more familiar to most of you, spend a little bit more time on phase 2, and then spend the bulk of the time discussing the impacts that we saw in phase 3. But what I want to stress here on this slide is really that it was very much a process, that we were really trying to build on existing work, on existing understandings, and to bring in people from this diverse range of in child development to provide as full a picture as necessary, as possible. And you'll see from the names here, we published these the papers on each of the phases in a special issue of AIDS. And so really this work reflects the sort of cumulative input of all the names that you see mentioned there. So phase 1, what can we say? I say in the last 10 years, we've seen a real huge increase in the amount of evidence speaking to the impacts of HIV on children. We used to focus a lot more on orphanhood and very narrow definitions of what the impacts of HIV were. And we had to guess a lot of it. But what we've seen in 10, maybe even 15 years of research now, which is showing detailed studies examining different points along the cycle of HIV to understand what are the impacts likely to be when an adult caregiver is ill. What are the impacts likely to be when they're on treatment? What are they likely to be when they become more seriously ill? What are they likely to be after death? And this gives us a much fuller understanding. And you see, if you go to the paper in the AIDS special issue, just the real wealth of data. And so what we see then is an ability to extract from that data a much clearer picture of what's going on. So we know already during the asymptomatic phases of HIV that there can be a number of risks to children associated with exposure to the virus during pregnancy, exposure to ARVs, can have its own set of implications, also during breastfeeding, and also particularly, we saw issues around caregivers may be preoccupied, and this raises an important issue around how we think about PMTCT programs. PMTCT programs do a great deal to help identify women and bring women onto treatment, and have been hugely successful in doing that. But it does mean that diagnosis of HIV is often during pregnancy. And when you receive information as profound as that you have been infected with HIV during pregnancy, it can have quite important implications for children, because we know that that key period of infancy is when you really need a caregiver to be absolutely focused on their child. And so we may need to think about how we counsel people during this period of time to ensure that, while doing a positive thing of identifying people and getting them linked to treatment, that we don't inadvertently do something negative. As illness progresses, we come into many of the more familiar impacts that we've seen around the economic pressure, whether that's from loss of employment or having to access treatment, even if you're not paying for treatment, physically getting to treatment services, missing days of work, so forth. Stress can be increased, and this can compromise caregiving. And then, of course, once a caregiver has died, we see issues around bereavement and potentially the changing of living arrangements. But what we really drew out of this literature was to say that actually, we know a lot about what these challenges are, but whether or not these challenges would actually lead to harm for children is determined a lot by the resources which are available to families to deal with these. So, the economic pressures, if there are large reserves of family resources that can cushion the impact of the economic pressure, then we're not likely to see an impact on children. Similarly, if there are appropriate supporting services in the environment, then the challenges we see will not be translated to challenges for the child. And also, certain children are more resilient than others. There are also issues which can make the challenges more severe or less severe depending on gender and individual characteristics. So the extent to which the preoccupation, the caregiver's stress on time, the economic pressures are translated into psychological stress or reduced consumption in the household or reduced access to services or even abuse is largely determined by the resources that are there and are able to protect the child. So we really were highlighting that the impacts of HIV, we understand them much better, and we understand that they're not inevitable, that they require other things to occur in order for them to go through to affecting the health, nutrition, education, and other outcomes for children. And what the review showed is that we have an increasingly detailed understanding of the magnitude of those impacts when they do occur. We can see that there can be serious health impacts, serious nutrition impacts, serious impacts on education, and a great deal of evidence now around the potential impacts on cognitive development, and also some additional evidence around child labor. So we've got this much more detailed picture of what we are seeing in terms of the impact of HIV on children. And so I wanted to go through that quite quickly, and there's the excellent review paper by Lorraine Scher and colleagues, which gives an overview of this literature, and I think it speaks to the wealth of research that has now been done in this area. But what was novel about this process was that we then wanted to take that evidence and give it to child development experts. And, you know, we really were very lucky to get some really strong academics involved in this process. So we asked people who were in fields which we had noted during the phase 1 were related to HIV. So we know, for example, that parent mental health can be affected by HIV. Obviously, HIV can affect parent illness and death. We have evidence that it affects nutrition, that it affects development, that it can affect attachment, and so forth. So all of these things that we knew that HIV had an impact on, we went to the experts in these fields and said, well, given your knowledge now of the long-term impacts associated with these challenges, what can we say about HIV? And you'll see the names here: Alan Stein at Oxford, Oscar Barberin, Ari Stein, Maureen Black, Marinus van Eisendorm, Jim Mercy, Seth Kultzman, and James Garbarino. All were asked to come in, and they all agreed. And these are really some of the top people in this field, and we were very fortunate to have them reflect on these issues and consider what the impact would be. And if you recall back to the paper that was published on this that I put on an earlier slide, there are far more authors than that, because these people kindly brought in a number of their colleagues and really entered into this process wholeheartedly and gave us a real detailed reflection. Now, as you can imagine, when you get together such experts and put them in one room and ask them to think these things through, there are lots of disagreement, lots of issues which they have, you know, when you take 50 years of literature or 100 years of literature, there are disagreements which have gone through those whole 100 years, and there are people on one side of an argument and people on another side of an argument. But despite those differences, and despite, you know, all the nuances and particular detail around each individual issue that was being covered, we found a lot of agreement. So some of the main points of agreement which we identified, I think, really speak to some very useful policy implications. And so while we were doing this with the view of building the model that I'm going to come to in a moment, the actual process itself threw a lot of important pointers to the way in which we need to be thinking about policy. And so some of the points of agreement which I think speak to that. So first of all, you know, we're talking about what proportion of children experience long-term impact and how serious are those long-term impacts. But nothing should take away that when faced with these difficult circumstances associated with parental illness or parental loss, all children experience some level of distress. This is not to belittle the stress that all of children affected by HIV or indeed infected by any of these other areas of study which we've brought into this process are not some ways distressed. But the key issue is whether these stresses become debilitating and endure over the long term, whether we start seeing the long-term impacts, really depends on a whole host of other factors. It's really sort of bringing in a more ecological framework. So there are issues around the child's biology, psychology, the family circumstances, the neighborhood, community, schools, other services which are available, which determine whether or not these impacts will turn, these stresses that occur during difficult times will be turned into long-term impacts for children. This was true of almost everything that we looked at. So whether it was exposure to violence and abuse, whether it was exposure to parental illness, divorce, all of these topics all come to the same conclusion that while it's stressful for all children, the extent to which it will be debilitating is determined by a host of other factors. And included in those other factors are issues to do with resilience and other opportunities to recover. And so it was very important from that stage already that we were highlighting the importance of looking at what are the positive factors which prevent these difficult circumstances becoming long-term enduring harm. And then one of the most profound conclusions in many ways, and one that's quite important to reflect on when we think about what the policy implications are, is that in all these domains we find, in all these areas of study, we find that most children with support will recover from these distressing circumstances, whether it's divorce, parental death, poor nutrition. Children can recover, and most children will recover. And that's really quite important when we think about how we target services, what are we trying to achieve with services at different points in time. So are we trying to prevent children from undergoing harm, or are we trying to help children recover? So this suggests already that the children who need to recover are a much smaller group that need additional support to recover, because most children in fact will recover. People are resilient, children are resilient. When there is no opportunity for recovery, all of the areas of studies that the long-term impacts are often serious and can even occur across generations. That from nutrition to divorce to institutionalization, we see very serious long-term impacts affecting children's cognitive development, their educational outcomes, their employment in the future, their mental health in the future, the way in which they care for their children in the future. So really quite massive impacts from early childhood distress. Then we find that although most children will recover, when there are multiple stresses, when there are multiple different adversities being experienced at the same time, and we're missing many opportunities to provide support, so you have a child who's facing many difficulties without many supporting services, then the probability of long-term negative outcomes really becomes much higher. And when they really accumulate to very many stresses at the same time, then we no longer see most children doing well. So if you take some extreme examples, like children in sort of dormitory-style institutional care at a very young age, almost all of those children will suffer long-term negative consequences. When things have accumulated to such a point, then it no longer becomes a majority doing okay. The individual stresses children can cope with. It's when they pile on together that they start to become more and more inevitable, or closer to inevitable, that children will experience negative outcomes over the long term. So that's important when we consider it alongside one of the other areas of common ground, is that many of these stresses cluster with poverty. So where there is poverty, there are often other difficulties for children at the same time, and this increases the probability and the risks for children in poverty. And what this highlighted across all of the areas then is this need for multi-level programs. So what I mean there is the need to think about preventing children from experiencing harm, and that needs to be far more broad-based. That needs to be looking to provide support to almost all children who are affected by adversity, or particularly those who are affected by clusters of adversity. And then much more concentrated, directed programs for those children who have actually suffered harm and are seeing signs of negative long-term outcomes. They need far more intense interventions. And we began to reflect on many of the interventions that we have in the field of HIV and AIDS tend to sit somewhere in between. They tend to perhaps be somewhat focused on the children that we think are experiencing harm, but not enough that they can dedicate sufficient resources to really try and reverse harm once it's occurred. And I'll come back to that point. So now I wanted to move on to the sort of modeling area, which is where I wanted to spend most of the time. And we really were only able to do this because we've now got quite a good understanding of what are some of the long-term impacts that we are looking at. But what do I mean by modeling, and why would we go about doing it? So a colleague who was involved in this process said something to me which has stuck with me very much, and I think is a very important thing to think about, is that you can build these models to predict the future or to try and better understand the present. And typically we think of these models as some way to say, well, what will the impact be in 5 years, 10 years, 20 years? What are we likely to see? And that's a useful thing for models to do, and that's a lot of what we use the epidemiological models in HIV to do. But actually, in something as complex as child development, it's very hard to be guessing exactly what the outcomes will be in 10 years' time. There's simply too many things going on for us to get a really accurate picture of that. But does that mean we shouldn't model? And we say definitely not, because in the process of examining the data to try and model, it helps us to a great extent be much clearer on what we do and do not understand. Because modeling requires you to be very precise about what you think the impacts are, and it causes you to have to really question the data in a detailed way. And I think in doing so, we actually learned a lot from the existing data that we have. So, for example, while we know that there are these many impacts of HIV in children, we don't know enough about whether or not these impacts are concentrated. So we know that children, for example, affected by HIV are at an increased risk of anxiety and depression. That's the way in which we reported in the literature. But we don't know, is that a small group who are exhibiting high levels of depression, or is that, many children who are exhibiting lower levels of depression? When you model, you have to understand this. We have to go back to the data and examine the extent to which the depression, for example, was concentrating in certain populations. Similarly, we know that children are at increased risk of depression. We know that they're also at increased risk of school dropout. We know that they are also at increased risk of abuse. Are these the same children? Are different children experiencing different outcomes? Or are we seeing children who are depressed also being the ones who drop out of school, also being the ones who suffer abuse? So which ones cluster, which ones don't? Again, we have to go back to the data and look at this. And we don't know the extent to which children will recover from some of these impacts over time. So if they're more at risk at one point in time of depression, is that going to stay with them? Is that going to get worse? Is it going to compound over time? We are very fortunate to have access to some of the data itself. Lucy Kluber, who runs the study for Young Lives, gave us access and worked with us through her data to actually re-examine these questions, and that was proved very useful in understanding the extent to which they concentrate, cluster. It's more difficult to examine compounding with shorter term data, but we were at least able to unpack the concentrating and clustering, and indeed they do. That it tends to be fewer children suffering a great deal, and that the risks and negative outcomes tend to cluster together, just as we saw in all the other fields of child development. It also causes us to re-examine issues around level and frequency of risk. So, for example, we know that HIV illness for a mother is associated with increased risk of her children suffering from abuse, particularly in the teenage years is where we have the data. That's a very serious concern. But when we start to model it, we start to see that there are not likely to be that many mothers who are ill while their children are teenagers, because by that time the mother is either on treatment or has died. And so while we know it's a very high risk, we know that it's probably likely not to be a very common risk. And that, again, is something we learned from combining the data we had that we perhaps wouldn't have learned beforehand. And what it brings out time and time again in the modeling is the importance to understand the interaction with the context. So in all cases, all the data we see is that HIV is magnifying a risk. But then the extent to which that is a concern is driven by the extent to which that risk was already high. And so in difficult contexts, such as poverty, when you see an increase in risk, particularly when it's multiplying the existing risk, then we see the real negative outcomes. What does modeling also do? It allows us to have alternative metrics. We've talked for a long time in the field of HIV about orphan numbers, which can then inadvertently lead to policies which are designed only to address orphans, whereas we know increasingly the children are at risk even while their parents are alive. Even when their parents are on treatment, some risk still remains. And so that really was why we wanted to get into the modeling exercise. And so what did we do? So we tried to model the impact of maternal HIV in the first instance on children. And so we wanted to understand the extent to which the maternal state of health, combined with their socioeconomic status and the child's age, gender, would affect school enrollment, mental health, the risks of abuse, and sexual behavior. And so this is now the model which I'll describe, which tries to do exactly this. So to give you just a sense of what we were trying to do, a quick slide on the model structure, sort of stylized version of that. So in order to do this, we needed to know what was the state of the mother at any point in time. Was she HIV positive? Was she negative? Was she symptomatic, non-symptomatic? Was she on treatment? And how did this differ between economic circumstances? And then linking that through fertility rates, which also vary by the maternal state of health and the economic environment. We wanted to map that onto the age of children when their mothers were in these different states. And that actually proved to be the most difficult part of the model. So to try and understand when mothers are ill, what age are their children likely to be, and how does that distribute across different income levels? And so we had to put a great deal of effort and data into linking that to the child outcomes that we see. And that gives us a sense then of the risk environment. So essentially all we're saying there is that we wanted to know what is the risk when, for a 7-year-old male when their mother is on treatment of a particular negative outcome, such as dropping out of school. That's what the model was designed to do. But then we obviously have to do that for both genders, all ages, and all stages of maternal disease progression. So what data did we use to do this? We used the model to run for a cohort of women. Now I want to just emphasize this for a moment. To model a population means people are being born all the time, and it can get quite complicated and difficult to unpack exactly what we are saying. So what we examined was a cohort of women born in, I think, 1985 in a South African context, and followed what would happen to their children for that 100,000 women that we see. And we used South African data as far as possible. The model can, of course, be calibrated to any country, but we wanted to use South African data because that's where we have the most data, both on the HIV epidemic and on the impacts on children. So it allows us to have data from a common source, which is preferable. And obviously then we take all the demographic data from there and all the HIV data from the South African context. We assume that half of the population lives in poverty, and we take a lot of the risk of negative outcomes for children from the Young Carers study, which I mentioned previously, but also from a number of other studies. So what does this begin to look like? So we can look at risks, pretending that if there was 100,000 women born or in 1985, what would the situation be for their children if there was no HIV? So we just get a sense of what is the impact of HIV for that cohort of women. So all this graph shows is the blue line shows the number of women who are alive by age and the number who are dead by age. And as you see, there's a drop from 100,000 quite steeply down in the first year, as you would expect from infant mortality, and then a very stable number of women alive, and gradually picking up in terms of mortality rates. You start seeing around 55 upwards. You start seeing a much steeper mortality curve until eventually in our model at 100 we don't have anyone alive. Now, if we use our age-specific fertility rates, we can start to look at what that means for children. So what that means for children is that at 1 year old, almost all children have their mother alive. There's a few deaths there, as you would expect, but not a high percentage. And that by 18 years old, the vast majority of children in the South African context would have their mother alive when they reach 18 years old, but just under 10% would have lost their mother for causes not associated with HIV. There's no HIV in this model. Now we can compare that to what would the risks look like if HIV were included. And that's where things start to get a little bit more complicated. So just to give you, again, a sort of stylized representation of what we were trying to do. For that cohort of 100,000 women, we needed to estimate how, they all start off uninfected, and then we need to estimate how many will become infected, whether they'll be diagnosed. If they're diagnosed, will they receive treatment? If they're on treatment, will they adhere to treatment? And then what are the mortality rates from all of those states? And actually, when we set out to do this, we set out to build a model of child outcomes, and we actually spent probably 70% of our time trying to link the maternal state to the child. Was by far the most difficult exercise. Now, you would think when doing this that the most important thing that's going to drive outcomes are the rate at which mothers become infected, so the incidence rate for this cohort, and the rate at which they get onto treatment. So numbers 2 and 7 in the presentation. And indeed, those two are important, and I'll show you that later. But what we discovered very early on in the modeling process is that what drove a lot of the outcomes was the extent to which, or the rate at which women were diagnosed and available for the pool to access treatment. If you're not diagnosed, you're not going to get onto treatment. And the rates of adherence. And I'm going to come back to particularly the rate of adherence in determining the outcomes for children. We started off with the view that it would be primarily incidence and treatment levels, and we ended with the view that adherence and rates of diagnosis are going to be particularly key in determining the impacts on children. So this is quite a busy graph, but it gives you a sense of how the states for mothers become much more complicated when we're trying to understand the HIV situation. The blue line, starting at 100,000, again drops with mortality in the early years, and then it's relatively stable from sort of 1 until 15 years, and then suddenly drops off very rapidly. Now, in this case, it's not dropping off to death. That's going from being HIV negative to HIV positive, and you see directly underneath that is a graph with a steep bump. That's when you're seeing many women becoming infected, and that's what the pattern that we know, that most women will become infected between the ages of sort of 15 and 25 is where we're really seeing the peak of incidence. And then gradually, because of that, you'll see a much steeper mortality curve, despite the fact that a number are going onto treatment. You see the treatment curve is a somewhat sort of orangey color, which peaks at around 40 years of age when the most women are on treatment. But gradually that declines as slowly women would die. Now, to link that to children, we need to know both the age-specific fertility rate and also the state-specific fertility rate. By state-specific fertility rate, I mean, what is the fertility rate for women who are HIV positive versus negative? What is the fertility rate for women who are ill versus those who are not ill? What is the fertility rate for those on treatment versus those not on treatment? So we had to gather quite a lot of data on that in order to have a sense of how we can map this on to children. And so what you already see here is that we're going to have a model which allows us to investigate how changes in treatment actually start to change fertility patterns as well. So when you have good access to treatment and have fewer women who are ill or are dying early, you will actually see an increase in fertility as women are able to have children for longer. So this gives us a sense of what is the situation for children. And so we see at 1 year of age now, we see close to 70% of children would be living with an HIV negative mother, but then quite a large proportion, close to 20%, would be with an asymptomatic and undiagnosed mother, and that's what you'd expect in the early years. So this is a lot of women who are in the early stages of infection and haven't yet been diagnosed. And you still see, however, a significant portion would likely be on treatment at that point. But gradually, as you approach 18, the number of women who have children whose mother has died would have increased. The number on treatment peaks when the child is around 10, but gradually the benefits of treatment wear off. But also there are fewer and fewer women, smaller and smaller proportion of women who are undiagnosed as a child gets older. And that's because they would either progress to being ill or moved on to treatment or have died. And so by 18, we would estimate in the South African context, we would be seeing just a little over 50% of children living with an HIV negative or having an HIV negative mother. And that means that close to half of children being affected by HIV in some way. So 30% or affected by HIV or mortality from some other cause. And so we see larger numbers than we would get in a model which only looked at orphaning. So orphaning, you will see, has now gone up to 30% from the 10% we see. So we're looking at 20% of children having suffered the loss of their mother as a result of HIV. But what we're suggesting is that's an underestimate of the full number of children affected, because there will still be, in addition to that, another over 10% of children who are living with a mother on treatment or is ill. Now, remembering the structure, once we know that, once we've linked the HIV state of the mother to the child's age, we have a sense of what the environment is for the child, and we begin to start trying to model the impact of that. Now, the one thing we added in here was to say abuse in particular increases the risk of all other negative outcomes. So we wanted to have some feedback. So once the child suffers abuse, we actually say that child is now at greater risk of all other negative outcomes. Now, that's probably true of some of the other outcomes we see, but abuse is the one that we had data on. So what we do then is actually run very, very simple models. We just want to know whether or not, for example, the child is in school, whether they've dropped out, or whether they've graduated. But what makes the model complicated is we want to calibrate this model and all the other outcome models by whether or not the child has suffered abuse before, because then all the rates will change, the status of the mother in terms of all those different health states, and the age and gender of the child to give us a fuller picture. So we have a simple model, but we essentially replicate it multiple times to take into consideration that ecological framework that we're trying to work with. So what does this impact look like? So this series of diagrams shows how school enrollment through the school years would differ with three populations. So the outer line is the outcome for all the children born to these 100,000 women if there were no HIV. The lighter blue line in the middle represents the proportion of children who will be in school at each year of school at the population level in a context where there's HIV. So this is not the children affected by HIV necessarily, this is those affected and those who are completely unaffected. So how much does it change if you like to think of it as national levels of enrollment? And the red in the middle is those children whose mother is HIV positive at some point in their life. And you'll see at age 6, you don't see a great deal of difference between the proportion of children depending on those scenarios. But by 17, you see a much more substantial difference, and we can draw that out. So in terms of school completion, the level of completion in a context like South Africa, we would have expected to be for a cohort of women for their children, which is expected to see 61% of children completing school. We're suggesting that, given our assumptions, that would drop to 57% for the whole population, and that would be driven by the fact that children affected by HIV would only be completing half of the time, 50% of the time, and school completion meaning completing secondary schooling. Now, what this highlights is that there's a large enough impact of HIV to be seen at the population level. So we're saying that the impact is so widespread that national completion, the average rate of completion at a sort of population of 100,000 would actually be affected by HIV. And that's a testament both to the severity of the impact, the move from 61 to 50, but also to how common that impact is likely to be. But what it also shows is that we have, 39% of children likely not to complete even in the absence of HIV. And that higher level of background risk comes out again and again in almost all the outcomes we look at, which is very difficult when thinking through what to do around programming when so many children are suffering from negative outcomes, even in the absence of HIV. And just to highlight a couple of the other impacts, so we looked in a similar way at the percentage of children suffering at least one episode of depression or anxiety by age 18. Again, higher background rates. Even in the absence of HIV, we were estimating that 45% of children would have suffered at least one episode, and that this would increase to 55% for those children who were directly affected by HIV. And again, because it's so common, that would increase the average for the population. So significant increases, but significant increases against a very high background level. And of course, these increases are not evenly distributed. They're really concentrated depending if you have lots of risk factors together. So this is a little bit stylized, but I think it makes the point. The bottom line here shows the cumulative percentage of children suffering at least one episode of depression or anxiety by age. And the bottom line is for girls in a high income, who've never suffered abuse, and whose mother's alive and HIV negative. And so you still see there significant chance that a girl will suffer at least one episode, so looking to about 30% by the end of their 17th year. But when you look at girls who now also living in a low income setting, have suffered abuse at some point in their life, and their mother has died, then you're starting to see almost 100% of those girls who've lived in that situation since 12 years old are likely to suffer at least one episode of depression and anxiety. So while we don't see massive changes necessarily for the whole group of children affected by HIV, for those who risk cluster, we're likely to see those large impacts. Again, repeating what we've seen elsewhere in the literature. So what does this say about interventions? What can we begin to understand from a model like this? So again, a bit stylized, but we put here a simple line, the top line, which is showing the proportion of children whose mother is deceased by age, and the blue line at the bottom shows that there's no HIV, and that's what we were discussing earlier, that only some 10% by age 18 would have lost their mother. If you introduce HIV and no treatment, remember our baseline is the results have been shown in the context is based on the South African context, which actually has higher rates of treatment access. You see that if there were no treatment, you would see a much larger proportion. So close to 40% of children having lost their mothers by the time they reach 18. Now, let's say 10% would have occurred anyway for other reasons, and then another 30% as a result of HIV. In the results that I've been showing you are based on high treatment, which already pulls that down quite significantly. You see the line added in now shows a drop in the proportion who's suffering loss. But this is still quite high, and these are quite high levels of treatment we have in South Africa. So this was a bit of a negative finding, and we spent quite a long time examining the extent to which this is true. And one of the things we did in this exercise was then to examine, well, what if we put treatment rates up very high? We did that, and when we put treatment rates very high, we do indeed see a further decline in the proportion of children who've lost their mother, but still a very large increase from the no HIV scenario. And when we looked at this closely, we discovered that it was largely being driven by the assumptions we were making about adherence to treatment. So diagnosis and getting onto treatment as well, but very much adherence. And if you think about it, it starts to make sense. So many women are being infected between 15 and 25. They'll have their first child during that period of time, and then they might go on to have a second and third child during their 20s and into their 30s. So for that woman to live, to see her child reach age 18, she has to live a long time with HIV. We're talking sort of 25, 30 years living with HIV in order for for her to see her child reach the age of 18. And while we know that's possible with treatment, that also requires high levels of adherence for that to occur. And so while in normal models that you see around HIV, mortality declines a lot when we put in treatment, we don't see the same decline because we're following a cohort. So you're not having new people getting onto treatment all the time. This is the same population of people, so they're getting older and older. And so it's very much driven by adherence. So when we do say let's increase adherence to very high levels, then we start seeing another big jump. So going from the high levels of treatment we have in South Africa now to even higher levels will make some difference, but not a huge difference. But increasing adherence to very high levels would start to make a big difference. Now, the model, of course, is stylized, and there are lots of limitations. We'll maybe just mention a few of those. We only include the mother at this stage. We're in the process of working on trying to find a way to include other adult caregivers. We're, of course, limited by the data that are available. During the early stages in the phase 1, we identified lots of issues related to HIV exposure during pregnancy, poor nutrition, child labor, and reduced access to healthcare, but we didn't have sufficient data to actually model those. People had used different measures. It wasn't as clear what exactly the impacts were, and so for us to extract from that and link it to long-term outcomes was very difficult. The risks of abuse, depression, anxiety were only available for children over the age of, for 12 years and older, and so we weren't able to include increased risks for younger children. And the role that PMCT plays in getting people onto treatment was difficult to model. So this doesn't actually change the total number of people on treatment, but it does change the timing of treatment in the model. And of course, the more pathways we add in, the more impact we will see. So we've been able to add in some of the direct links between maternal state and negative outcomes. And we've considered how those change, whether they occur in the context of poverty or not in the context of poverty. But we're beginning to try and examine, well, what happens if poverty increases as a result of HIV? Then you're getting an increased risk from poverty and the increased risk from HIV. And so we're looking for ways in which to introduce that. But what can we begin to say in terms of the implications of this? And what's interesting is that the implications of the modeling very much echo the implications we saw in the phase 2 work from the broader child development literature. And that's not surprising. We look for common ground in the broader child development literature, and it's not surprising that HIV shares that common ground. So we found widespread risk and high levels of underlying risk, which suggests the need for large-scale prevention of harm. So we're seeing, in a context like South Africa, where we see very high prevalence, we're looking at 30–40% of children affected by HIV in some way. So that's a very large proportion of children, and to protect those children, you need large-scale programs to reduce harm, made even larger by the fact that underlying risks are already so high. So it suggests that very broad-based programs for some sort of prevention approach. But the long-term impacts, the impacts that are likely to endure into adulthood, are much more concentrated and they cluster together, which means we may need to be thinking about intensive targeted mitigation interventions. And so, interventions which prevent harm, huge, try and cover as many children as possible. Interventions which try and respond after the child has started to experience negative consequences in their own development need to be much more intensive if we are to see a difference. So maternal infection, illness, and transition to treatment or death occur mostly in those early phases. If you saw the graph, the busyness for the mother is at an early stage. And so while we're coming so often to look at older children, those are the children who are more likely to be in a stable situation, where the mother's already dead, but those transitions that are occurring from being diagnosed to getting on treatment are much likely to be occurring when children are young. So we may need to be linking to PMTCT programs for that. And this suggests that there's also an opportunity for combined adherence and family support. Programs for children affected by HIV, for orphans and vulnerable children, are at the household level. Many of the barriers to adherence are also at the household level. So given that adherence is so important, if mothers or indeed fathers are to see their children reach at least 18, there seems to be a good ground to try and support adherence within the household. Not to distract services for children from their primary task, but to reinforce to try and strengthen the interventions by also supporting the adults who can then provide further support to children. And this is not to suggest that they start doing different things such as counting pills and becoming adherence supporters directly, but just saying when you are doing support for economic strengthening in the household or other forms of family support, that is done in a way which makes the most of that intervention for adherence. And of course, because I'm a researcher, I have to mention that it's clearly that we need more data, particularly longitudinal data, so that we can follow up on these issues. And just to then finally mention that we are working with USAID PEPFAR to think of ways to extend it to additional caregivers, additional pathways, possibly to look at different countries. We've done this with South Africa. Can we do it for other areas? And then possibly extend it to looking at child development more broadly. Again, not to predict, but to try and better understand what are the things that are going on. And we're thinking about that in terms of, for example, maternal depression. But a lot of this is talking to, we go in the children's field from the sort of very ecological framework, saying that everything determines child outcomes, to very isolationist, where people are talking about, well, we need to do just this intervention. And what these models bring out is that we can, to some extent, look at the interactions. Not all of them. We can't go to building full ecological models, but we can understand some of the interactions and avoid trying to isolate key interventions when really the interventions that are needed have to have many parts. Things don't work in isolation. That to see the benefits for children, you have to have a number of different interventions reinforcing one another. And we are hoping that we can draw more attention to that important interaction. So thank you very much, and I look forward to your questions. So yes, we looked at the South African context, and it certainly does make a difference. South Africa has an incredibly high HIV prevalence, so we would not be seeing the same impacts on sort of population level outcomes in contexts where there were fewer HIV, where the rate of HIV was much lower, and so that would make quite a significant difference. But the point that we're making, that the numbers affected by HIV are always going to be more than orphans, I think something we accept, but an estimate of that, those are likely to be similar. So while a lower prevalence country wouldn't have the same numbers involved, we would again be talking about maybe a doubling of children affected by HIV from the estimates that we get from orphan numbers. So the second question is, does the model include mother-to-child transmission of HIV? So this model looks primarily or solely at children affected by HIV. We were not looking at HIV infection among children. There are models which have done that, and we thought that this would be a complement to those rather than trying to repeat what they have done. And we definitely see the developmental challenges for children who are actually infected with HIV are obviously far greater. And in the literature that we reviewed, we did include some of those in phase 1, and we see how much stronger those are. But the overwhelming impact of mother-to-child transmission interventions and the impacts of HIVs are around mortality and health, and we were much rather focusing on outcomes such as education and so forth. So does the adherence data consider information on HIV drug resistance driven by inconsistent or low adherence? To an extent. So the way we modeled adherence was to take the approach which is taken by the AIDSTAR model, which is a population HIV model in South Africa, and so we calibrated it to that. And the AIDSTAR model has spent a great deal of time trying to match the model results to the mortality patterns that we see in the country. So, but then they don't separate out what is the cause of some of those mortality patterns. And so while it would have issues to do with drug resistance in there, we can't separate that out. So to what extent does the implication of widespread risk applicable in countries with more moderate? So very similar to the first question. The risk is definitely going to be, what we're saying is that the risk is definitely higher than the orphan numbers will lead us to believe, but obviously will not be as large. South Africa has a very intensive epidemic. So the proportions of children that we're talking about would only really be relevant in a Southern African context, Botswana, Namibia, Swaziland, and so forth, but not more generally. That I would encourage people to go and take a look at the special issue of AIDS, which was done on this, and 3 papers. I could not possibly do justice to all the thinking from the large group of people that were involved in this. And I think the compilation that's in the Sher et al. Paper really gives you a very nice sense of what we know about the impacts of HIV. And then the second paper really was a sort of crash course in child development, inputted from a host of some of the really top people in the child development field. And so just reading through those 2 papers, I would really encourage anyone interested in this field, because it brings out a lot of the subtleties which we can't cover in this presentation. John, I don't know if there are further questions.
Hi, Chris. We don't have any in our chats right now.
Right.
Any final thoughts on your end?
No, just to say thanks all for listening in, and we are trying to take this work forward. So if there are people who are interested in this, feel free to contact me, and I'll be happy to chat to them.
Great. Thank you so much, Dr. Desmond. It's been a very thoughtful and informative presentation.
Great. Thanks all.